Good morning. Welcome to our October Walk to Wellness. I'm Amy from Hartford HealthCare. Thank you all for being here. I love seeing your pink and I love the attendance here. It's wonderful. We have the pleasure of having us with this morning Dr. Duckworth. She's a breast surgeon with the Hospital of Central Connecticut. And she'll be joined by Tina Verona, who's our Director of Media Relations. And we look forward to this talk. It's important to kick off Breast Cancer Awareness Month, so thank you all for being here. I'm going to pass it over to Dr. Duckworth and Tina. Thank you.
Thank you, Nadia. Good morning, everyone. Good morning. Oh, it's so lovely to see all the pretty in pink that I see out there. It's so wonderful to see that. But you know, behind the beautiful color is a very important message. And it's a message that we highlight all this month during Breast Cancer Awareness Month, that early detection through screening mammograms is absolutely critical in saving lives. It gives you a fighting chance. I'm so happy to be joined by Dr. April Duckworth. As Nadia mentioned, she's a breast surgeon with the Hospital of Central Connecticut. Good morning, Dr. Duckworth.
Good morning.
Thank you so much for being here. You know, all this month we highlight breast cancer awareness, but really this is something that we should be doing all year long with our friends, with our girlfriends, but even men too. Men do get breast cancer, albeit a small percentage. But let's talk about screening mammograms and the importance of screening mammograms.
So screening mammograms is our best way to find breast cancers when it's still very, very small and very curable. Many women, they try to avoid doing their mammograms because either they're scared of the radiation or they're scared of the results. And a lot of what drives the fear of the results is, you know, the unknown of the treatment of, you know, the word cancer. But the key is if you find it still very, very early, when it's very small, before it's went anywhere else in your body, then you are in the realm of 96 to 98% survival rate, which is why you see so many women who do survive breast cancer, because we all know people or have been personally affected ourselves with breast cancer. So please do not avoid getting your mammograms.
And even before that, Dr. Duckworth, I want to emphasize self-breast exams that women should be doing on a consistent basis. You should really know your body. Talk to us about an effective self-breast exam. How do you do that?
So ideally, so what I recommend is, if it freaks you out, then let me do it. If it empowers you, then you should do it. But ideally, you choose one day of the month. Don't do it every week, don't do it every day. Just choose one day of the month, same time, and you start typically standing up. You start in the same position. You just work your way so that every part of your breast has been felt. And if you notice anything that's new, like you feel and you're like, oh my goodness, there's a lump, and then you feel it one way and there's something there, but then you feel it a different direction and it disappears. Take a deep sigh. It's just breast tissue, and then continue to move on. But if it feels all different directions, you still feel a lump, then you should tell your PCP or your GYN, or you come and see us, and we'll see what's going on.
And having that familiarity is so important, because if you're doing these regular self-breast exams once a month, you're going to know when something doesn't feel quite right, because you're doing it consistently. So Dr. Duckworth, not always does breast cancer present itself with a lump. Some women are diagnosed by a routine mammogram and they don't ever present any symptoms or a lump. Talk to us about how effective, because the mammogram is still the gold standard of detecting breast cancer.
Correct. Most women today, their breast cancer is actually diagnosed on a mammogram. So it still remains, like, if you have to choose one imaging modality, your mammogram is it. With women who have dense breast tissue that's seen on mammogram, then that's where the ultrasound comes into play, which it also is very good at finding the things that could be hidden on mammogram. but most breast cancers are not actually felt.
And I want to talk about dense breasts. There are many women out there who have dense breasts. When you have dense breasts, a mammogram is just not enough. So you would require ultrasound screening. Talk to us about that. After the mammogram, you would have your ultrasound.
Correct. So if on the mammogram it is deemed that you have dense breasts, which basically means that when they're looking at the picture, there is black and white. So if you see more white on your mammogram, then you're considered dense breast, and that's where the ultrasound comes into play, because pieces of calcium, asymmetries, masses, they look white. So if you have more white than black, things can hide. So the ultrasound is very good at picking up these things that can hide in just a normal mammogram.
I want to ask the women out there, how many of you had a mammogram in the last year? Excellent. That's pretty much everybody. That's what we like to see. So we have a crowd that's really
Strong
engaged.
word.
Yeah, really engaged in their health. So we like to see that. Once cancer is detected, and take us through that process. So a woman comes in for a mammogram, maybe there's some calcifications that's found on that mammogram. What happens at that point?
So if it looks like there possibly could be a mass associated with those calcifications, or there's an asymmetry that looks like there's a mass, then we would do an ultrasound to see if it can be seen with an ultrasound. If it is seen with an ultrasound, then an ultrasound-guided biopsy would be the next step. If it's not seen, then it would be what's called a stereotactic biopsy, which uses the mammogram to do the biopsy. Once the biopsy was done, depending on where you have the biopsy done at, we can get the pathology anywhere from 2 business days to about a week. And then you would meet with your surgeon, who would discuss the pathology, and depending on what the path is, for most women, surgery would be next.
And let's talk about some of those surgical options. You hear about lumpectomies, you hear about mastectomies. Let's talk about some of those options that are available to women today.
Right. So for the large majority of women with breast cancer, your surgery is your choice. Whether you do a lumpectomy, which the official name is a partial mastectomy, which is where you remove the area that has the cancer, have normal tissue around it, and you leave the rest of the breast. The alternative is to take the whole breast, which is a mastectomy. There is no survival difference between the two. But with the lumpectomy, in the large majority of cases, you get radiation.
And we have some men in the audience too. I do want to make sure that we address male breast cancer. How rare or how common is it? How often do you see it?
It's very rare. It's only maybe like 4% of all diagnosed breast cancers. So not very common. But typically men who present with breast cancer, they feel a lump or they have nipple discharge.
And let's talk about, it can be, it's a scary diagnosis to hear that you have breast cancer or really any type of cancer. What's available to women to help with that emotional, sort of mental health and well-being after you receive a cancer diagnosis?
So all of the programs have nurse navigators who are wonderful resources of support groups. There are in-person support groups. There are also many support groups on Facebook, are just like self-arranged, like through church. There's like a wealth of information as to where to go to receive support. There's also social workers who help on the financial aspect of it, because there are grants which assist. Breast cancer is very well funded compared to some of the other diseases.
Yeah. I want to go back to the surgical process, whether you choose a lumpectomy, a radiation, or a mastectomy with reconstruction after. Let's talk about that and the options that women have today in terms of the surgery that they choose?
So with reconstruction, that can be done also with partial mastectomy, because some women use their cancer diagnosis to get the breast reduction or the breast lift that they've always dreamed of with the lumpectomy. But with the mastectomy, there are different ways or you have different options. One choice would be to go flat, so you don't have reconstruction. And another choice would be to have tissue expander / implant-based reconstruction, which is what most of the plastic surgeons here in the Hartford region and also in the Central region do. There is an option to use your own tissue. It tends to be more like the pannus that's down here. You use that to get basically your boob job. So you get a tummy tuck and a boob job all at the same time. Although it sounds great, but it's a lot of surgery up front.
Yeah.
So it's a very invasive and involved surgical procedure.
And with that invasive surgical procedure, what is the recovery like?
So the one where you use your own body tissue, which is the more favored one, is the DIEP flap. You typically stay overnight in the hospital for like 3 to 5 days with a higher nursing care, and then it's about a month of recovery, and you have 2 sets of incisions because you have the one in the belly and the one in the chest. With the implant-based reconstruction, initially you start with a tissue expander. You stay at least one night overnight in the hospital, but most people go home the next day. And then about like 6 or so weeks later, you return to the operating room where they exchange the tissue expander with the permanent implant. So the reconstruction process there is also a little bit more prolonged.
You know, family history is so important. You know, if you have a first-degree relative that had breast cancer, obviously that's very important. But all too often, we hear about women with no family history developing breast cancer. Talk a little bit about how common that is becoming.
Yeah, it's very common. Most people think because it's not in my family, I will never get it. And that, in fact, is not correct. There's only 20% of breast cancer diagnoses that are related to genetic mutations. So it is the minority of women. Your risk factor is the fact that you're female and you have breast.
Yeah.
And some people are like, well, I have very small breasts, so I shouldn't get breast cancer. That also has nothing to do with it. It does tend to be women with dense breast tissue. They have a higher risk.
After a woman is diagnosed and after the surgery, after the recovery, she is watched by somebody like yourself, and depending on what type of cancer it is, there may be hormone therapy that comes into play. But what is the follow-up care like after breast cancer surgery?
So once you complete the surgery, typically I would see you about a week later post-operatively. So we'd go through the pathology, see how you're healing. We'd get you in with the medical oncologist and the radiation oncologist. And then I would see you at 3 months. And at that time, if you chose to do a mastectomy, then there's really no further imaging that's required. If you chose to have implants, then they do recommend, the manufacturer recommends having MRIs every 2 to 3 years after implant placement. But many women, they don't necessarily do that, 1, because they don't like MRIs, and 2, because insurance often won't cover those. But if you have a partial mastectomy, the follow-up would be, we would meet when you're due your regular mammogram, and then we would just pick up where you left off.
And when a woman has breast cancer, what are the chances that of reoccurrence? You often hear recurrence. You often hear of words like metastasize and things like that. Let's talk a little bit about that.
So reoccurrence after a partial mastectomy with radiation is less than 10%. After a mastectomy, it's less than 1%. A lot of people also ask, what are my risks of developing a new breast cancer? And that's around 0.5% a year. So you know, if you're 80 and you developed your first breast cancer, that 0.5% is not very concerning. But if you're 20 and developing a breast cancer, that 0.5% adds up. So most likely they will develop a second breast cancer when they are older.
And let's talk about rewind a little bit back in the operating room when you're having your procedure, whatever it is, a lumpectomy or a mastectomy. There's what's called the Sentinel lymph node biopsy that's done in the operating room to take a sample to test your lymph nodes to see if the cancer has spread into the lymph nodes. Talk a little bit about that, and then the risk of metastasizing to other parts of the body.
So that gets a little kind of in the weeds per person and their own pathology. But we do test the lymph nodes at the time of the initial surgery, pending you meet there are some women we can omit sentinel lymph node biopsy from at this day and age, just because there has been a test called an oncotype, which is a lab test, which actually gives us more information than what the lymph node would give us in prognosis. But many people, what they're concerned about with the lymph node is the possible side effect of it, because taking just a few lymph nodes, there's a risk of lymphedema, which is the swelling of the arm, which is less than 3%. But if it jumps up to where you have to have all your lymph nodes removed, then it jumps up to 30%, and that is a lifelong problem. If it's caught early enough, it is thought to be reversible. But for most people, by the time that it is caught, unfortunately, it's more you have to prevent the progression instead of curing you from it. So if you've seen women walking around with sleeves, like the compression sleeves, that's kind of their history. So I know it didn't really answer the metastatic question, but
right, no, and of course, and we do want to stress, obviously, every case is very individualized, so that personalized, coordinated care at the Hospital of Central Connecticut that Dr. Duckworth and her team provides is so critical, because every woman is different. There is no one cancer diagnosis that is the same.
True, because many women think, oh, breast cancer, it's all the same. But the reality is there's one woman's breast cancer is not necessarily the same as another, because there are a lot of genetic components within the tumor itself that kind of dictates the aggressiveness of it. But fortunately, most women, they have hormone positive, low to mid-grade breast cancer, which the large majority of people do very well with.
Lots of variables, though, with each diagnosis. I'm sure there are a lot of questions from the audience, so I'm going to turn it over to you guys out in the audience. I see one hand up here right away. Good morning. What's your name and your question?
Hi, I'm Fern. I have a question about genetic counseling. I understand that not everybody can just go in and say to their doctor, I want genetic counseling. So I have a family history. My mother's sister had breast cancer a couple of times. So anyway, when I go for my mammograms and my talks and stuff, and they said that because of my family history, I would be a candidate for the insurance company or whoever in the sky would allow the genetic counseling. Do you think at this time and age that should be more prevalent for more people than, because you have this or that? And I chose not to do it because I'm one of those, if I have it, I'll worry more about it than if I don't. Just if it happens, it happens. I just felt it should be more available to more women.
So if any person wants to have genetic counseling or genetic testing, whether they have a family history or not, you can always pay for it out of pocket. And I think it's around $250. The question is whether insurance would pay for it. Which, if you don't have a family history or personal history, then it's pretty unlikely that insurance would pay for it. But if it is something that you want to do, I think it's around $250, which isn't cheap, but it's not like $12,000 like what it was in the 2000s.
Amount of money, but that's something that you could just talk with your GP about or your GYN. Okay.
Any other quote in the back? Okay. Coming. Here we are. Good morning. What's your name and your question?
My name is Gloria. And my question is, the mammogram for women who are 80. I've never had breast cancer, and I get it every year, many times they even tell you about things like a colonoscopy. Oh, you're fine after 75. Well, I have a neighbor who has stage 3 colon cancer. So I'm all in favor of a regular mammogram for everybody, regardless of their age. And I'm glad that I'm in the Hartford network and I get it.
Wonderful. Oh, that was more of a comment. Thank you for that. Any other questions? Right here. Good morning. What's your name and your question?
Hi, Cassandra. Good morning. I was just wondering, is there a difference between like a portable mammogram van that comes around and the other place?
You talking about the mobile mammography van?
Yes, yes.
So the mobile, they're screening mammograms. So, you know, if it's there, it's available, it makes it easy, and it keeps you doing it, then it's worth it. If you need like any additional imaging, so diagnostic imaging, you would have to go into like a center that has the mammograms that are there. But that's more to do with the radiologist's presence.
Okay, cool. Oh, sorry, Cassandra, go ahead.
So, like if you had dense breasts, would the mobile machine be just as good?
Oh, are you talking about the ultrasound then?
Yeah.
Yeah, well, I don't know if the ultrasound is on the mobile
Right.
unit. I think it's just the mammos, which are available there.
Okay, we have a question from a gentleman. Good morning, your name and your question.
Good morning. My name is Fred. I think you said something about tissue therapy is part of the healing process.
What? I'm sorry. I only caught like a.
I think I heard you say tissue therapy was involved in the process of possibly healing.
I'm not sure what you mean by tissue therapy.
I'm kind of relating to stem cell therapy.
Oh, at this time, I think stem cell is all still one slightly controversial, but two still in research development. But we don't do any like stem cell injections or anything like that. I think that's more in line with like the lymphomas and leukemias, but I'm not 100% sure.
Good morning, what's your name and your question?
Cheryl, I wanted to know, 1 year it's dense breast, the next year it's not, then it goes back to being, why is that the fluctuation? It's the same place I go to, same radiologist.
It's, as I mentioned before, it's the black and white and how the radiologist feels that day. Like some people are very obviously dense and there's no question. Some people are very obviously not dense. But there are many women who kind of fall where some days they're dense, some days just depending on the radiologist and kind of which way they lean, whether they're more conservative and they'll lean more toward recommending ultrasounds or less conservative and less ultrasounds. So
is it the radiologist that's changing, but I'm still staying the same, or am I changing?
it's most likely the radiologist.
Oh, okay.
Any other question right here? Good morning, what's your name and your question?
Hi, my name is Karen. I was wondering if you could tell me what the incidence may be of cancer following microcalcification diagnosis. You know, what percentage you've seen, or you know, what's the percentage chance of it developing into something?
So how often are microcalcs found to be cancer?
Or develop into?
So what we look for on mammograms is changing. So some women have little pieces of calcium in their breast, and as long as it stays the same, then it never triggers anything. If it starts to increase in number, then that's when we tend to do the biopsy. The large majority of those are benign. It'll be this benign breast tumor that starts, called a fibroadenoma, that as we get older, they start to shrink, and when they start to shrink, they'll start to deposit pieces of calcium. Or usual ductal hyperplasia, which for some reason, but ever so often, I think it's like a fourth of the time, do we find these increasing little pieces of calcium are cancer, which is significant enough to want a biopsy. But just because you need a biopsy, don't jump to thinking, oh my gosh, you know, it's the end, because it's not.
Question over here. Good morning, what's your question?
Yeah. the recurring of the breast cancer usually fall on the same side, or they will be on the different side of breast?
So if it's a local recurrence, it would be the same side. And that after a partial mastectomy with radiation is less than 10%. And after a mastectomy, it's less than 1. If it's on the other breast, then that's a completely new cancer, because it very, very rarely goes to the other breast. And that the risk of developing a new breast cancer on the other side is around 0.5% a year.
Back over to Cassandra for another question.
Doctor, could you tell me where, like if you do have breast cancer and it metastasizes, are there certain places it could go more so than others?
Can you repeat the question?
If you have breast cancer and it metastasizes, where would it go? Some places more than others?
So breast cancer tends to go to the lungs, to the liver, to the bones, and to the brain. There are also rare cases where it'll go, or not that rare, but it doesn't very often go to like the colon, but it tends to be more bone, lungs, liver, and brain.
Good morning.
Hi. You didn't mention whether the use of radiation or chemotherapy, what's the percentage of each and what's the advantage or disadvantage of each?
So chemo and radiation, they're two completely different entities, and they have different goals. So radiation is for local treatment, so that purely is for your breast and your armpit. Chemo is more for systemic. So there are certain things that we look at, so like tumor size is one of those, or your hormone status. If it is a hormone positive tumor, then we rely on the genetics of the tumor itself to dictate whether or not the person would need chemo. That test is an oncotype. If it's like a triple negative or HER2 positive, which again, I'm getting a little bit into the weeds, then there are these subtypes and they all depend, they mean different things. So to say like the percentage is hard to generalize. Does that make sense?
Well, is it dependent on the doctor's opinion or?
No.
There's parameters that you go by.
It's the pathology, correct?
Correct.
Yeah.
It's based on the pathology.
Hi, good morning. Your name and your question?
I'm Carol. Regarding mammograms, what is tomosynthesis?
So tomosynthesis, they also call it the 3D mammo. So the standard mammogram was they would do 2 views and they would basically take 2 pictures. With the tomo, they do more of a 3D view, so they take multiple pictures, and what that allows you to do is it's kind of like in a sense, a CAT scan to the breast, but nowhere near the radiation exposure.
So is it becoming more common?
Yes, if you have a choice, you should do a tomo.
Good morning. Your name and your question?
My name is June, and my question is that breast cancer removes some lymph node, and then if the margin or the lymph node find the cancer cell, what's follow-up procedure, and would that affect to others, the PET scan needed or some other, screening needed?
So usually we save a PET scan kind of for last case. If we wanted to know if you had breast cancer anywhere else in your body, we would do a CAT scan and a bone scan. And if something seemed suspicious on that we weren't able to biopsy, then we would do a PET scan.
Any questions in the back? Great questions, by the way, this morning. Good morning. Your name and your question.
Yes, my name is Mary. I know that chemo and radiation plays a vital part in any type of cancer. Is it the patient's choice to have the radiation or chemo?
So it's always your choice because it's always your body, and you're the one that has to live with what's done to it. We will strongly recommend one or the other or both, just depending on where you are with your pathology and your surgery. So you know, in certain cases we strongly recommend it, but there are times even for like the anti-hormones where the risk of the medication doesn't really like outweigh the benefits. So then it's an honest conversation you have with your treatment team as to what you think is best for you. I mean, chemo tends to be a little bit more you need it or you don't. Radiation is a little bit you need it, you don't. But the anti-hormones like tamoxifen or anastrozole or Remedex, you know, a lot of women is recommended to take it. And compliance, because it's recommended that you take it for 5 years, but what they don't talk about is compliance after 3 years kind of drops off. And the reason is because kind of, you know, it makes people feel not quite themselves, and you're far away enough from your cancer diagnosis that you've lost the fear of it coming back.
That's true.
And now you're like, does this actually, you know, does my insomnia, does my thin hair, do these hot flashes, are they worth it to me?
Yeah.
And then that's where you have to make a personal choice.
Absolutely. Thank you.
And Dr. Duckworth, in the first 5 years after a cancer diagnosis, is that critical time period when there could be recurrence?
So 2 years is the big marker, and then 5 years is the next.
Okay, right over here. Your name and your question?
My name is Paula. My question is, if there's a 20% hereditary predisposition, what's the other 80% causes of cancer?
Well, that's the thing. We don't know all the genes that predispose someone to develop breast cancer. So of the genes that we know, there's only 20% of the women with them. The other 80% is either environment, like bad luck in a sense, or like an unknown genetic mutation. Because I do have patients who have a very strong family history, but their genetics are completely negative. It just means that there's probably something there, or they all drank the same bad water. I don't know.
We're going to take one more question, and if you have additional questions, Dr. Duckworth will be here after the presentation, so if you want to talk to her, we encourage that. One more question? Somebody have a, no? Oh, I guess, oh, okay. Well, Dr. Duckworth, I always like to end on a positive note. You know, we covered a lot of ground. We talked about a lot of very important information for women, and really I just hope the takeaway here for women is if you haven't had your mammogram, please get your mammogram. I can't stress enough how important it is. It will save your life if it's caught early. You have a fighting chance. So let's talk about in terms of the future of breast cancer. You know, 20, 30 years ago, it was a death sentence, right? And today it's not. There's women that are living active, productive, healthy lives with breast cancer. What does the future hold?
Yeah, well, there are active, healthy women living with metastatic breast cancer.
And yes, exactly.
And there are enough women that they have a yearly conference. And if you think about it, on TV, we hear commercials advertising to breast cancer patients. If those women were not there to advertise in a significant amount, there would not be commercials. You don't see commercials advertising drugs for pancreatic cancer or ovarian cancer, and it's because women survive breast cancer. So stay on top of your imaging.
Yeah, and I do want to end on a note. Every chance I get, I encourage women, obviously, to get mammograms one person at a time. And one woman who I know very well, I had asked her if she had her mammogram. And she said, you know, I'm 48 years old, and I never had a mammogram. And I was lockjawed. I said, what do you mean? You've never had a mammogram? And she said the reason she never had a mammogram was because she wanted to be there for her 2 young boys. And I said to her, that is all the more reason you should have your mammogram. And she went and she had her mammogram, and fortunately everything was fine, and she's now on that right track. But I can't stress it enough. I want to thank all of you. I want to thank especially Dr. April Duckworth, breast surgeon at the Hospital of Central Connecticut, and for you, all of your wonderful questions this morning. I'm Hartford HealthCare's Tina Verona. Thanks for joining us. Be well.